Okay? فالheart failure is a really bad disease. Okay. These are my disclosures for this presentation. And heart failure is not something which is uncommon. It actually affects a lot of people around the world. Okay, it's not moving. في حاجة صح؟ هي moving عندي مش moving هناك. على مهلك. فهو heart failure is not an uncommon thing. It occurs around, 26 to 37 million عشان في ناس undiagnosed. This is one. Number two, it potentially can affect 1% of the whole population due to aging, due to other problems. Well, heart failure, as we know, is individualized according to the phenotype of the ejection fraction. لما نعمل echo, heart failure is a clinical diagnosis, symptoms and signs of heart failure. دي أهم حاجة. لما يكون عندي ejection fraction below 40, this is heart failure with a reduced ejection fraction. Above 50, this is a preserved ejection fraction. واللي بين الاثنين اللي كنا بنسميهم طب ما كان صوتي جايب القاع حلو قوي. اللي هما بنقول عليهم mid range. Now it's called the mildly reduced, and these are my disclosures. So this is heart failure in numbers. And the problem with heart failure, the mortality is quite high. It might surpass some cancers. Worse and worse, it is always in a chronic decline ويحصل acute exacerbations. It's not going to be stable. Even if the patient seems stable, he or she are not. And the mortality rises by time. حاجة تانية, this is the most debilitating symptom-wise disease. It's really important to understand أسوأ حاجة هي symptomatology في heart failure. لكن كمان حاجة, the worse the symptoms, the lower the NIHA class, يعني 2 غير 3 غير 4, the higher the mortality. عشان كده, when we want to treat heart failure, we want to reduce mortality, we want to improve symptoms, and we want to reduce hospitalization. لأن hospitalization has 2 problems. It reduces mortality when we stop the hospitalization or reduce it, and it reduces costs. أكتر حاجة مكلفة في أي منظمة صحة في العالم هو heart failure hospitalization. أول سؤال, do you think we can prevent heart failure? Of course, yes. How? Treat hypertension, treat diabetes, this is good. لكن do we have evidence of medications that can prevent heart failure? Let's take a look at dapagliflozin. The landmark trial in type 2 diabetes was the DECLARE. طبعا, there was a reduction of heart failure hospitalization and the composite of cardiovascular death. MACE was not reduced on the overall population, but in the high risk it was. لكن heart failure was reduced significantly. Regardless العيان كان عنده established or unestablished cardiovascular disease. ولو بصينا على الداتا من كل الستاديز بتاعت التايب 2 diabetes, EMPA-REG, CANVAS, DECLARE, there was a significant 30% reduction in heart failure hospitalization, even in those who did not have heart failure. How about the treatment for heart failure? This is another important thing. Heart failure used to be, without any, the patient's gonna die. No treatments. Diuretics, digitalis, ACE inhibitors came in the late 80s, and then some things came up. بعد كده in the 2000s or the late 90s, we saw some beta blockers. We saw data للmineralocorticoid antagonists, لكن بصراحة في الألفينات we had a boom. عندنا طبعا قبل ال SGLT2 طبعا الARNI, this is an important thing, the sacubitril valsartan. عندنا الداتا اللي بعد كده was breakthrough. SGLT2 inhibitors, and this was really important. لأول مرة 2019 in a large controlled randomized study was called the DAPA heart failure, that non-diabetic patients, نص العيانين كانوا non-diabetic, were given a treatment that has only been approved for treatment of type 2 diabetes. This was the most sought after study seen in the 2019 European Society of Cardiology, أكبر مؤتمر القلب. And it was looking at those with heart failure, reduced ejection fraction, below 40, and giving them medical therapy. arm هنديله فوق الميديكال ثيرابي dapagliflozin 10 milligrams, والarm الثاني just the medical therapy that we give, sacubitril valsartan, بندي beta blockers, MRAs, and so and so and so. What happened? There was a significant, this was the first study on HFrEF with an SGLT2.
there was a significant reduction in the primary endpoint: cardiovascular death, heart failure hospitalization, or urgent heart failure visit. ولو شفتوا ال p-value, very highly significant, and the number needed to treat is very low, 21. طب ممكن العيانين استفادوا؟ عيانين لا. ممكن استفادوا type 2 diabetes والnon-diabetics ما استفادوش؟ No. All patients benefited, whether diabetic or non-diabetic. طب يمكن العيانين اللي خدوا الأرني عشان كان لسه طالع was much better and they did not benefit from the SGLT2 addition. No. Every single patient, regardless of his or her medications, بياخدوا 1, 2, 3 pillars of heart failure with reduced ejection fraction, all of them benefited, all ways towards the benefit. احنا قلنا برضو عندنا the quality of life is really important, and the quality of life here was improved significantly. يعني not only was heart failure hospitalization reduced, cardiovascular death was reduced, but also the quality of life was very good. وباين هذا regardless of the phenotype of the patient or the phenotype of the heart failure or the concomitant other comorbidities اللي عند العيانين. So this is really important regardless to know that dapagliflozin in the DAPA heart failure improved outcomes regardless of the patient's status. This is really important. But did it come on top causing adverse events? Actually, there was no increase or signal of adverse events, a little bit more of genital infections, nothing else to worry about, not even ketoacidosis or hypoglycemia. معلش, clicker stopped. Okay, thank you. These are the important. فبقينا عندنا بدأ 3 important parameters, medications that reduce mortality with heart failure and reduced ejection fraction. لو الACE and ARNI, البيتا blockers, مش كل البيتا blockers, MRAs, بقى SGLT2s, DAPA and empagliflozin. So this is really important. خلاص, they're a cornerstone regardless of the patient has diabetes or not. Heart failure with reduced ejection fraction, SGLT2 is to be written in all of these unless the patient is in type 1 diabetes, and this is a contraindication. وكمان الanalysis showed if you add these medications early, you can have a survival free, يعني فرص الوفاة أقل, and longevity can be extended up to 8 years according to the best of treatment you give for your patient. ولكن في مرض تاني ما اعرفش حضراتكم aware بيه ولا لا, مش يعني sometimes يعني slips between our hands, اسمه heart failure with preserved ejection fraction. The patient is symptomatic, edematous, congested, but the ejection fraction is above 50. And actually no data has shown any outcome improvement for heart failure preserved ejection fraction. كان كل الداتا لو congested اديله diuretics if the patient has a comorbidity to treat the comorbidity, and that's it. لغاية ما جه 2 studies. It started off with the Emperor preserved, and now we have the Deliver in 2022. كان ال Deliver study ايه؟ الناس اللي عندهم mildly reduced with preserved ejection fraction, and ejection fraction above 40, وعندهم evidence of heart failure with preserved ejection fraction, بدل ما عالجهم في الكوموربيديتيز وعالج الهايبرتنشن وعالج الاسكيميك heart disease and stuff like that, I can add in one arm dapagliflozin 10 milligrams and in the other arm just leave them as is. What happened? The point, and this is the second time an SGLT2 shows the primary endpoint being significant in heart failure with preserved ejection fraction. The composite of cardiovascular death or worsening of heart failure was significantly reduced. Number needed to treat, again, quite low, 32. Mainly pushed باللي احنا قلنا عليه, what is really important, heart failure hospitalization was reduced and worsening of heart failure. And this is the components of the primary endpoint. You can see that the worsening heart failure, اللي هو heart failure hospitalization and urgent heart failure visit was significantly reduced. Cardiovascular death, not to that significant. الأهم, it didn't differ زي الداتا بتاعت الساكيوبيترول valsartan. Sacubitril valsartan in HFpEF is excellent when the ejection fraction is below 50, but above that, it doesn't work. But here, look at even the subgroups of ejection fraction. Above 60, there is a 22% relative risk reduction. كمان الناس اللي هم enrolled within heart failure hospitalization within 30 days. كمان الناس اللي حصل لهم improved ejection fraction, they benefited even more, even if their ejection fraction improved, of adding an SGLT2 to those and that. كمان it didn't differ according to the diabetic status or not. It didn't differ according to the age, gender, or ethnicity, body mass index. You can see always, it's always pushing that dapagliflozin did a better outcome. Again, there was improvement in the symptomatology, هنا بالKansas City Cardiomyopathy Questionnaire, and the adverse events like the DAPA heart failure were not increased. If you look at the data collectively بقى, أنا عندي heart failure symptomatology من قبل ما أعمل له echo, هل ممكن أبتدي الداباجليفلوزين؟ Yes. If you look at the pool data, regardless of the ejection fraction, إحنا هنقلل cardiovascular death significantly. هنقلل all-cause death significantly. هنقلل total heart failure hospitalization by nearly 30%, which is important and significant. The first heart failure hospitalization is reduced by 26%, and the cardiovascular death, myocardial infarction and stroke are reduced by 10%, which is also significant. So these are very important data that regardless of the ejection fraction, adding dapagliflozin 10 milligrams reduces outcomes, reduces hospitalization, improves the quality of care of our patients. How did this impact the guidelines? This is really important. احنا هنقول, are this data that you are showing us really recorded in the guidelines? How look? In the American 2022 AHA-ACC guidelines for heart failure, you can see if a patient is at risk of heart failure, diabetic at risk of heart failure, ما عندوش heart failure, ما عندوش حاجة structural, given SGLT2. This is the guidelines, مش كلامي. If the patient has risk factors that can lead to heart failure, lower stage B, add an SGLT2 for diabetics, because this was studied in the DECLARE study. If the patient has evidence of heart failure with reduced ejection fraction, فيش نقاش, class 1A, and empagliflozin, dapagliflozin, to be honest, it's only those. It's not any SGLT2. And if the patient has heart failure with mildly reduced or preserved, كان ساعتها, عشان كان لسه ما طلعتش الداتا بتاعت الديليفر, البول داتا بتاعت الديليفر والامبرور preserved, كان الكلاس of recommendation 2. لكن for the very first time, the European Society of Cardiology عمرها ما بتنزل focused update زي الأمريكان. Very first time, السنة اللي فاتت حطوا focused update for heart failure. لأن الداتا بتاعت الديليفر والامبرور preserved was so compelling that now in heart failure with preserved ejection fraction, we give diuretics for congestion, class 1. We give dapagliflozin, empagliflozin for treatment of heart failure, preserved ejection fraction, and we treat the comorbidities. Best. We don't give a lot of other things because they have not shown to reduce the primary outcome. So to take home, heart failure, as you see, is not something nice. You've seen it with your patients. It's very deleterious. It causes a lot of comorbidities and a lot of problems and complications. SGLT2s that started off as a treatment for type 2 diabetes have now expanded to the cardiovascular system, heart failure across the ejection fraction. CKD now is really booming. And their impact on heart failure led to their inclusion in even non-diabetic patients, and they've shown their safety. Data from the DAPA heart failure and deliver studies show us that even if we diagnose a patient by symptoms, regardless of the ejection fraction, we can start dapagliflozin 10 milligrams because it is guideline recommended, it has been shown to improve outcomes, and it is there for our heart failure patients. Thank you so much.